Hi, my name is Kimberly LeBlanc, and I'm the Academic Chair for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm coming to you today from Ottawa, Canada, and I really wish I could be with everybody live in Abu Dhabi, and I hope that you have a great Congress. Today I'm going to give you an introduction to skin tears. Here's my faculty disclosures. So today I really want to get into defining skin tears, giving you an overview of the scale of the problem, the risk factors and causes, and how to classify skin tears. So let's jump right in. We'll start by defining skin tears. And skin tears are traumatic wounds that are caused by mechanical forces, including the removal of adhesives. Severity can vary by depth, but it doesn't extend through the subcutaneous layer. And skin tears can be complicated or uncomplicated. So here we can see skin tears as an acute wound, but as the skin tear becomes complicated, it becomes a chronic wound. Scope of the problem, well, we know that in long-term care, globally, there is a pretty big spread, but we don't have a lot of data available. Here in Canada, our prevalence range is around 20 to 24%, whereas in areas like Japan, it's been as low as 2.2%. In the community, we've found it everywhere from 4.5 to 19%. In acute care, from 6 to 11%, in palliative care, from 3 to 14%. And the intensive care operating theaters, the prevalence really isn't known. And there's also very limited literature available for the pediatric population. If we look at the anatomical location of skin tears, they can occur anywhere on the body. However, we know the majority will occur on the upper and lower extremities. So ranges of skin tears, where do they occur? Well, we know they occur from blunt force trauma, falls. They occur while performing activities of daily living, dressing or treatment related, during patient transfers, and equipment injury. But we also know that almost half of skin tears are found with any apparent documented cause. So we looked at the risk skin tear framework. Some of the things that is important to keep in mind is that skin tears, we can look at the individual variables. So these are things that are intrinsic to the individual, such as chronic or critical disease, aggressive behavior, dependence on others for activity of daily living, history of falls. And then there's having a history of previous skin tears, skin changes that are associated with aging, and photo damage. What's important to note is often in the literature, you'll hear that skin tears being advanced age is a risk for skin tears. But what we've discovered is that it's really not the advanced age that's causing someone to develop a skin tear, but rather the skin changes that they have with aging. And photo damage, so that sun exposure damage, is really one of the big contributing factors. But not all of these individuals who have these risk factors will go on to develop a skin tear. So what we need to look at then is our mediating factors. Now, if we look at the mediating factors, we discover that, well, we know that mechanical skin trauma, such as shear, friction, or blunt force, individual caregiver or healthcare professional. So what are their knowledge, attitude, and practices? And the physical environment. Can we remove things that are going to contribute to them having a fall, for instance? And then we have the healthcare setting as well. What kind of attitudes and supports are in place from the healthcare setting? And we know that if we can't control or remove the mediating variables, so if we can't control how the attitudes of healthcare professionals and how they apply and remove dressings, for example, then what can happen is we'll get a skin tear development occurring. So we really need to make sure that we're controlling those mediating variables as much as possible. We need to be aware of the individual variables, and we need to control those mediating variables. Now, the International Skin Tear Advisory Panel validated the three-type classification system. So type 1 is when we have no skin loss. So we have a linear or flap tear, which can be repositioned to cover the wound bed. We have a type 2 partial flap loss, where we can't reposition the flap over the whole wound bed. And then we have a total flap loss. So here you can see schematic drawings of a type 1 skin tear, a type 2 skin tear, and a type 3 skin tear. So when we're caring for skin tears, it's really important that we remember these are acute wounds that should heal in a timely fashion. So we should expect them to heal in that 14 to 21 day range. So first and foremost, we remember that these are acute wounds. We need to control the bleeding. We need to cleanse the wound well. We need to reapproximate the wound edges. Then we classify and document. Then we move into a holistic approach to care, which includes treating the cause, implementing a prevention protocol, moist wound healing, avoiding trauma, protect from the peri-wound skin, manage exudate, avoid infection, and pain control. And remember that one of the top causes of risk factors for having a skin tear is actually having a history of a previous skin tear. So here you can see where we have a type 1 skin tear before and after we reapproximated the flap. And here you can see we have a type 2 skin tear where we were not able to completely reapproximate the flap to cover the wound bed. So keeping in mind, once again, that healing trajectory, that we expect wound closure in 14 to 21 days. And this is when you have a non-complicated acute skin tear that has not become a chronic or complex wound. Now, there's the pitfalls of skin closure strips. If the wound is not completely approximated, there's an increased risk of wound infection and delayed wound healing. And unfortunately, we also see with these skin closure strips that on removal, they will often dislodge the flap or cause another skin tear. So the International Skin Tear Advisory Panel has come out with a statement saying that we should avoid using skin closure strips. So some of the recommendations that ISTAT made is that when you're treating skin tears, you need to assess, make sure you don't add new risk for trauma, and assess for comorbidities such as venous disease, arterial disease, pressure, mobility issues. One of the things that I see a lot is when you have someone who develops a skin tear on their lower leg, and if they have lower leg edema, then you need to address the edema as well. So you need to do that complex, comprehensive lower leg assessment to assess, can you put compression on? And I often, anybody who can support having compression, I will go ahead and put them in compression if their lower leg assessment is appropriate. Right away, I will put them in compression therapy. And then we see these wounds will close in those 14 days. But it's really important that you do that lower leg assessment. And we're going to choose a dressing that's going to decrease trauma, provide moist wound healing, and manage pain. So when we look at wound closure, we know that here's some of my horror stories I see looking at skin closure strips, sutures, and staples. Remembering that, especially with sutures, that peri-wound skin is so fragile that whenever possible, sutures and staples should be avoided as well. We want to make sure we're protecting that tissue flap. So we want to make sure that we're putting on the dressing and we're marking which direction we should be removing the dressing in. And that's going to aid in making sure that we're not dislodging the flap when we remove the dressing. And Dr. Wu and myself conducted a pragmatic randomized control study to evaluate the use of silicone dressings in the treatment of skin tears. And what we found was quite interesting, actually, in terms of the reduction in surface area between this control group, which were non-adherent dressings, and the treatment group, which were soft silicone dressings. And here you can see that we had almost double the 3 times the amount of surface area reduction at week 1 when we looked at the control versus the treatment group. But what I found really interesting was the time to heal. So here what we found was with our soft silicone group that we actually had healing that occurred 50% faster among the treatment group versus the control group. And we looked at proportion of healing. We found that at week 3, almost 97% so at 21 days, almost 91% or 97% of our treatment group went on to closure versus 34.5% of our control group. So this is promising evidence to show that soft silicone dressings do actually aid in the healing of skin tears. Now, we need to do more studies, further research is needed. However, this is a promising first start. If you want to learn more information about skin tears, I invite you to visit the International Skin Tear Advisory's webpage, www.skintears.org. So visit the ISTAP website. And in May of this year, if we're still online, we will be at our national conference, and we invite you to check us out and come visit us. And here are my references should you have any additional questions. I hope you have a great rest of your Congress.